Good morning, respected faculty, respected chairpersons, our president, Dr. Pankaj Garg, and secretary, Dr. Shamina, and all respected delegates. We welcome Dr. Devendra Srin also, who is from Rajasthan, and we will also welcome Dr. Dolly Madan. I request our president, Dr. Pankaj Garg, sir, to say a few words.
Good morning and welcome all. IIP Delhi has been in forefront of academic activities throughout the year. And for last 2 years plus, we have been doing this master classes in different specialties on Sunday morning, 9 to 10. Last years, we did it for in the field of neonatology, hematology, endocrinology, and we have this rheumatology course. And today is the last session. We did 12 sessions. Today is the 12th one. Every morning, 9 to 10. Rheumatology is a comparatively untouched field. And this course was very successful. We had closer to 350 registrations and many people joined online, and then these sessions are also stored on the YouTube channel of IIP Delhi, where a lot of hits are there and people keep on watching it later on also. And after this session we will be sending the e-certificates to all the participants, and from next Sunday, that is 11th May, we will be starting the pediatric cardiology e-master class, which is again 12 sessions, same time 9 to 10, and all the important pediatric cardiologists are participating in that session. So those of you who want to attend, please attend that session also. So with this, I welcome Dr. Sanjeev Joshi, our EB member CIP, and Dr. Nikhil Pathak, another EB member of CIP. So thank you so much for
Morning.
sparing your time for this activity of IIP Delhi, and I definitely welcome Dr. Devender, Dr. Sham, the program coordinator, Dr. Ajay Gupta, Dr. Dolly Madan Madam, and Dr. Anu, who was the main people who compiled all the programs and designed this program in very, very nice fashion. So thank you all, and happy learning. Over to Dr. Ajay for starting the session. Dr. Ajay. Dr. Ajay, you're on mute. You're on mute. Huh.
Unmute.
Yeah.
I request Dr. Shamina, secretary, IIP Delhi, to say a few words.
Hello, very good morning to all. Greeting from IIP Delhi team, and I would like to thanks to our previous chairpersons as well as today's chairperson, Dr. Sanjeev Joshi and Nikhil Pathak Bose, and I would like to thanks to my all speakers. They nicely cover the majority of the part of this rheumatology issues, and definitely I would like to thank. They nicely conclude that. Because rheumatology is a very vast topic, and they nicely cover the all things by the case scenarios. That is one of the important things that I got the feedback from my different participants as well as our faculties. And I would like to thanks our CIP EB member from Delhi, Dr. Mukesh Dhankar, Dr. Manish Gupta, Dr. Mukesh Verma. They definitely give a lot of the input for this program. And I would like to thanks to today's guest of honor, Dr. Anju Singh, and because this program only made the success because there's a brain behind this program is Dr. Anu Maheshwari, Dr. Ajay, Dr. Dolly Madan, Dr. Neha. They are the main pillar to behind the success of this program because they did the wonderful job to make the successful of this program. And I would like to thanks to my office staff, Sushil ji, Anil ji. They also because without technology we are not able to continue give the such a services on e or Zoom platform. So I would like to all entire team to support directly indirectly to make this program successfully, and other things definitely at the end of this session my president will declare regarding the benefit of speakers as well as chairperson as well as participants. Thank you. Over to Dr. Ajay.
Thank you, Dr. Meena. I also welcome Dr. Bennett Xylem, sir, and Dr. Anu Maheshwari, who is the chief advisor for this program. And today's chairpersons are Dr. Nikhil Pathak and Dr. Sanjeev Joshi. Dr. Nikhil Pathak is EB member from Maharashtra, and he successfully organized National Conference of Pediatric Infectious Diseases last year. And Dr. Sanjeev Joshi, sir, is the past chairperson of the neurology chapter of IIP, Central IIP. Just one.
Not audible, Ajay. So,
And he's executive board member of Central IIP, and he's ex-national secretary of neurology chapter and Vidarbha Pedicon, chief organizing chairperson of the Vidarbha Pedicon. I request Dr. Sanjeev Joshi sir to please say a few.
Good morning, all. The president of Delhi AOP, my good friend Dr. Pankaj, secretary, young dynamic secretary Dr. Sham Meena, dear friend Dr. Ajay, all the other luminaries from the Delhi AOP, my EB colleague Dr. Bennett, Dr. Nikhil. First of all, Dil se Shukriya for this wonderful opportunity to interact with the Yuva pediatricians across the country. As we all know, rheumatology is one of the emerging field in the field of pediatric also. And I was just talking one day to Dr. Bala from Chennai. So he just told me, Sanjeev, there will be one day that the most of the patient in PICU will be on biological rather than antibiotics. So this will be the future is really challenging, and to empower our young pediatrician colleagues. This is a wonderful initiative by Delhi AOP. Hats off to you, entire Delhi team, for conducting this master classes. So my job is to introduce our today's speaker, who is none other than Dr. Narendra Bagri. He is a faculty from AIMS Delhi, trained in Bristol in the field of pediatric rheumatology, and of course he will be speaking on the Sjogren syndrome and USRD. As we all know, Sjogren syndrome is an autoimmune disease of exocrine gland. The three cardinal clinical manifestations we all know are dry eyes, dry mouth, and arthritis. So the previously it was called as Sika syndrome. So with this brief introduction, I think am I allowed to hand over the mic to our speaker?
right, sir, right, sir.
Yeah.
Before
So
that, I
over to you,
request
Dr.
Dr. Nikhil
Narendra.
Patil sir to say a few words. Dr.
Yeah.
Nikhil, would you like to say something?
Uh, Good morning, everyone. So I have been lucky to study in Delhi. I have been from DDU and I have completed my DNB from there. So Delhi has always been an academic hub. And last 2 years, Ajay sir is running this mastery class. I have been following it up regularly. So first of all, thank you for inviting me to chair this thing. And hopefully we will get a very good knowledge about Sjogren syndrome today. So thank you very much. Good morning.
Thank you, Dr. Nikhil. Over to Dr. Narendra Bagri sir.
Yeah, good morning, everyone. Thank you, chairpersons and organizers, for giving me this platform and the introduction.
Sent a long message.
Am I audible?
Yeah,
Yes, sir.
you're
Perfect.
Can
Fine.
you increase the volume a little bit, sir?
Okay. So just give me a second. I think. Let me know if you need something else.
No,
So-
it's okay. Thank you.
Perfect. So am I audible and visible?
Yes,
Yeah.
screen is
Okay. Fine. So I'm starting, but I mean, can someone suggest me? I just want okay, it's okay. I mean, I'm not able to see others, but hopefully you all are able to see me.
Yes.
Yeah,
Yes, sir. Sir, please make it full screen.
able to see you well.
Okay, fine. Okay.
That's great.
Yeah, that's fine.
Mm. I want to minimize this so that my slides are visible.
Okay, sir.
Fine. Okay, so this morning I will be taking you through relatively rare, but clubbed together, they might account for few patients with rheumatic conditions. And my aim would be basically to touch upon when to suspect this condition. And that would be good enough for today's webinar, I think. So let's begin with the case unit. So here is a 8-year-old girl. And I'm pretty sure that all of you must have encountered such cases somewhere in OPD sometime. If not, you may find it coming week. So here is an 8-year-old girl who was presented with cervical lymphadenopathy, recurrent parotitis, and painful swelling of the submandibular salivary gland. And these recurrent parotitis episodes are there, I mean, for last 2 years or so. Thoughts? I would be happy if it becomes an interactive session. I'm sure that everybody must have encountered recurrent parotitis. And say, for example, this is an 8-year-old girl, and she's having these symptoms for last 1 year. Either you can express your thoughts verbally, or you can put on chat box and someone can let me know the thoughts of the audience. What are they thinking?
So the delegates can put the comments in the question answer box.
Yeah. So that is not accessible to me. If someone can help me with that, if someone is... Yeah, I could see that. I could see some responses, yes. So any thoughts? I'm pretty sure that these cases you must have encountered some point in time. So I can
request delegates to answer in the question answer box.
Yeah, you can answer in the question answer box, or those who can speak also. I'm happy with either way. But I want to just start the discussion with what actually can happen tomorrow morning in OPD. You must have encountered these cases. Someone is writing connective tissue disorder as the possibility. Can be stone in parotid duct. Yes, perfect. So the first point I want to disclaimer is that there is no substitute to clinical thinking, and you should have to be wise. I mean, your origin of thinking should not be restricted or tunnel to rheumatic disorders only. As someone pointed out, yes, it could be very well a stone in the parotid duct. That's fine. But apart from that, there is submandibular gland involvement and there is cervical lymphadenopathy. So, and submandibular parotid, both enlargement, stones in 2 places might be difficult. But one common entity with probably the senior colleagues must be aware is about entity known as juvenile recurrent parotitis. So this entity usually is a benign entity. So every parotid swelling may not actually be Sjogren, or at the same time, every juvenile recurrent parotitis that we assume may actually be juvenile Sjogren syndrome. So how do we differentiate between these two conditions is probably the most important thing that I would like to decipher from this particular case. And if you can, I can summarize this. Basically, this is a study where people have this group of authors have done, and what they have shown otherwise also is that the juvenile recurrent parotitis usually starts a bit early. The usual median age is around 3 to 6 years of age, and they will have recurrent parotitis, which usually is painful. Whereas the Sjogren syndrome, the age is bit older kids, 8, 9 years and older, and then often they may have painful or painless parotid swelling, as the chairperson has rightly pointed out. And he has also mentioned that the other features, if there are there, the Sicca symptoms. But it is important to note that the Sicca symptoms may not be present in all kids, unlike adults. Reason being, they may not be actually able to, express these symptoms. That could be one reason. And at the same time, because of the pathogenesis itself, they may not be they have not been widely reported in pediatric population. So in addition to parotid swelling, if we have other features like Sicca symptoms and serologic, for example, ANA is positive, immunoglobulin levels are raised, and in such cases, we will definitely consider a possibility of Sjogren syndrome. So the Sjogren syndrome could be either primary or secondary. By primary, I mean that it is not associated with any other autoimmune disease, whereas secondary Sjogren syndrome is Sjogren syndrome where the symptoms of Sjogren syndrome are there in addition to an underlying other rheumatic condition. For example, classic example is systemic lupus erythematosus. Subsequently, the child develops Sicca symptoms, parotid swelling. So this is a secondary Sjogren syndrome. One of the cardinal features, recurrent parotid gland swelling, Sicca symptoms characterized by dryness of eyes or mouth, and then systemic features like arthralgia, arthritis, and other visceral organ involvement can also happen in children with Sjogren syndrome. Let's have this slide just gives you a picture, glimpse of how there is the understanding of Sjogren syndrome is improving. So the first time the Sicca syndrome characterized by dryness in oral, ocular and vaginal reason was described way back in 1925, and then the term keratoconjunctivitis sicca was coined. Subsequently, as the other things evolved, the drugs first used were steroids. Subsequently, hydroxychloroquine was used as one of the drugs for the management of Sjogren syndrome. And then there were studies to demonstrate the abnormality in the parotid gland or the salivary gland using salivary flow rates or scintigraphy. One important association, in particularly for adults, this holds true, is the association of lymphoma with Sjogren syndrome. And then in 1982, the classic autoantibodies, which are associated with Sjogren syndrome, but are known as anti-Rho or anti-La, were described. So coming to the clinical features, it's not that common in pediatric population, as I told in the beginning. But if you look at the large series from various parts of the world, we can see it usually has an indolent course. By that, I mean, it will often keep on lingering with slow, smoldering features for years before the diagnosis is being made. To simplify, the clinical features can either be glandular or extraglandular. By glandular clinical features, I mean the swelling of the parotid glands. And as you can see, this is present in most of the series as ranging from 50% to 3/4 of the children can have these glandular swelling. Of course, the other symptoms like constitutional symptoms, fever, arthralgia can also be present. The extragranular presentation would again depend on the extent of the disease and the duration of the disease. But of noteworthy, important, particularly for pediatric population, renal involvement. What is the classic presentation of what are the classic renal manifestations of Sjogren syndrome? Any thoughts? For postgraduates, if they are around, this could be, or for, good MCQ kind of a question. If I will be happy if I can see any comments. What are the renal manifestations of Sjogren syndrome?
So someone has answered DRTA.
Perfect, fine. So yes, so DRTA or interstitial nephritis can be a renal manifestation of Sjogren syndrome. Likewise, the other manifestations could be pulmonary, where they can have ILD. In central nervous system, they can have neuropathy, or at times they can have hematological manifestations with anemia, and so on. So what is the basic pathogenesis? This basic pathogenesis basically is the simplest form I can explain. Probably holds true for most of the rheumatic conditions, including Sjogren MCTD. So what is happening is there is an overlap of, there is some environmental trigger, and eventually what is happening is there is an production of autoantibodies through B cells. And in this particular case, the autoantibodies are anti-Rho or anti-La antibodies. And apart from that, there would of course be T cell activation, which will lead to the sustained inflammation. One of the important finding is overproduction of interferons. And why it is important is that subsequently down the line, we'll see that this has got a therapeutic implication. As if we can see that if there are lots of autoantibodies formed, then it means that if we, by some means, if we can block this autoantibody formation using any drug, any thoughts, which might have a therapeutic implication on this. Drug which can block the production of B cells. So maybe you can consider rituximab, which might help preventing this. Okay, so having discussed the basic clinical features of Sjogren syndrome, let's come to the classification criteria. And this is the criteria mainly proposed for pediatric population. Reason being, what is the difference between the adult and pediatric Sjogren? The key features are, number one, the salivary gland or glandular features are more common in pediatric population. The parotid gland enlargement is an important feature. Secondly, is renal tubular acidosis is more common in pediatric as compared to adults, and therefore these parameters have been inducted inducted for this particular classification for primary Sjogren syndrome in children. So to simplify, the domains here are clinical symptoms. The clinical symptoms are classically the Sicca symptoms, which includes the dryness, ocular, entire. So the clinical symptoms are Sicca symptoms first, which includes the dryness in oral cavity, eyes, or vaginal area, and then immunological abnormality. This again is important. Presence of at least anti-Rho or anti-La antibodies and high titers of ANA and rheumatoid factor positivity is found in most of the patients with Sicca symptoms. There could be other biological laboratory parameters. One of the important clues is once you get the immunoglobulin levels done. Whenever you are suspecting a child with Sjogren syndrome, or for that matter, most of the rheumatic conditions do get the total immunoglobulin levels. And what you can get there is the immunoglobulin levels are usually raised, but in Sicca symptoms, the Sjogren syndrome, the immunoglobulin levels are markedly raised, and that's why it's an important criteria in the proposed classification. In renal involvement, you need to get renal tubular acidosis, and of course, we need to document the lymphocytic infiltration, basically, which is the etiopathogenetic genesis behind why there is salivary gland involvement is because of the lymphocytic infiltration of the salivary glands, and this has to be proven through histopathology or through other means. For example, xylography, of late ultrasonography is also being done for demonstrating the abnormality in that. So in labs, we have to look for hemogram, which can lead anemia, and lymphopenia is an important marker. ANA is usually positive. Anti-Rho or anti-La antibodies should be present. Hypergammaglobulinemia is an important marker, as I told you. Schirmer test is nothing but a test which will just quantify the tear production of the eyes. And if you put the Schirmer test, if the tear is less than 5 mm, it will qualify for a positive Schirmer test, which is suggestive of Sicca symptom found in this. At times, minor salivary gland biopsy is often the recommended biopsy for Sjogren syndrome. And what you do is this is the biopsy from a labial biopsy, the lip biopsy. And the classic feature here is, if you can see the figure, see here, there are dense lymphocytic infiltrates. So this is a focus of lymphocytic infiltration, which is defined as more than 50 cells in this particular cluster. And if you have a focus score of more than 1 per 4 mm square area, then this biopsy would be suggestive of focal lymphocytic sialoadenitis consistent with the diagnosis of Sjogren syndrome. Now we have understood that the parotid gland enlargement is an important feature of Sjogren syndrome. This would reflect. This would reflect by dysfunction in the parotid gland, and that the usual function of the parotid is to create saliva. And here we can demonstrate that the salivary gland scintigraphy, if you do scintigraphy, the patients with Sjogren syndrome may have reduced uptake and secretion, or it is delayed as compared to the normal, and this would suggest Sjogren syndrome. So we have learned that the Sjogren syndrome, the dysfunction in the parotid gland can be demonstrated either through biopsy, scintigraphy, but more non-invasive tool is salivary gland USG. And in expert hands, what you can get is salivary. There are cystic lesions in the parotid gland, and they are usually found in one of the possibility is Sjogren syndrome. Can someone tell me the other possibilities for cystic lesions in ultrasound of parotid gland? So usually, I mean, there are only a handful of causes for this cystic lesions in parotid on ultrasound. One of them is Sjogren. Another is, we discussed, recurrent parotitis, which may actually evolve into Sjogren if they have other constitutional symptoms. And one is, of course, HIV. So let's move on to this case. So here is a girl who is presented with fever, Sicca symptoms, for progressive pallor. And you can see that there is anemia. ANA is positive, and the ultrasound shows bulky kidneys Urine exam is essentially normal. And then down the line, from onset of these symptoms, a year later, she started having polydipsia. Thoughts? So here is a girl who has Zika symptoms, constitutional symptoms, anemia, ANA positivity, and on top of that, she is developing polydipsia. What do you feel? How do you explain? How do you club together everything? So would you, let me make it simple. Would you keep a possibility of Zika symptoms, in this? Dr. Pankaj has written RTA, which is a perfect thought. And this is because of the fact that this girl has got polydipsia, and we understand that in Sjogren syndrome, the patients can develop RTA. And this was actually the case here as well. And what you can see is in the investigation, this girl has anti-Ro positivity, ANA positivity, lymphopenia is there, and then you get Akum positive anemia. And here is what Dr. Pankaj is highlighting. There is acidosis, and this is RTA. And on ultrasound, there is also medullary nephrocalcinosis. And what this is again one point that I was highlighting earlier, that immunoglobulin levels are very high in Sjogren syndrome. And the Schirmer also is positive. So clubbing together, and the renal biopsy suggested tubulointerstitial nephritis, which is a feature of Sjogren syndrome. So clubbing together, this girl has dry eye, Zika symptoms, positive autoantibodies, recurrent parotitis, abnormal, we have not done salivary gland biopsy, but we have seen that this girl had other features consistent with the Sjogren syndrome in form of tubulointerstitial nephritis and autoimmune hemolytic anemia, thus qualifying for the Sjogren syndrome. So how do we treat Sjogren syndrome? In this particular case, we had used steroids, hydroxychloroquine, azathioprine, and of course for RTA, we did use urinary alkylating agents in consultation with our nephrology colleagues. And last follow-up, she is doing well, and you can see that the acidosis is also improved. So the management principle of Sjogren syndrome, as I've told, that this particular syndrome is a very indolent course, has got indolent course, and the various organ involvement can happen over the time. So basically the treatment also would depend on the underlying organ involvement. For most of the cases, for example, if someone is having just dry eyes or dry mouth, in those cases, probably you just have to use supplements, for example, TS supplements or chewing gums or maneuvers, which might increase salivary flow. And then one important, because of the poor salivary production, these kids are at increased risk of dental hygiene. So they need a regular dental check just to rule out any caries. And then agents like pilocarpine hydrochloride have also been used to increase the salivary flow. Then the other drugs, which are immunomodulators, can be used depending on the organ involvement. Like the previous girl, where there was arthritis, there was prominent Zika symptoms. Later on, she also developed tubulointerstitial nephritis. So we have escalated, and on top of Coombs positive anemia, she had required steroids and azathioprine. At times, if there is a progressive lung disease or bad arthritis or bad overall symptoms, biologics like rituximab may also be considered for management of Sjogren syndrome. So what's the prognosis? So overall, in summary, the prognosis of Sjogren syndrome is better as compared to adults. The risk of lymphoma is less in juvenile Sjogren syndrome as compared to adults. And overall survival rate for 10 years is more than 90%. But why it is important to identify these disorders is because of the quality of life. And to improve that, if someone is having these symptoms which we have discussed, think of Sjogren syndrome, screen for the organ involvement, and decide the treatment as we have discussed. Let's move on to this case. So here is a girl, 13-year-old girl, who has presented with this discoloration of hands, what is classically known as Raynaud's phenomena, swelling of fingers, and there is some reddish knuckle rashes over the metacarpophalangeal joint. arthralgia, photosensitivity rash. Possibility. What is the possibility? What possibility you will think in an adolescent girl with Raynaud's phenomena, photosensitive rash? What is the possibility? What would you think in an adolescent girl with Raynaud's photosensitive rash, arthritis?
Someone has answered vasculitis and
Okay.
lupus. Sealants
Oh,
for
vasculitis or lupus. Perfect. So this could be either, I would keep lupus a bit higher than vasculitis, but yes, that can turn out to be some vasculitis as well. Okay. So perfect. Down the line, she also started having myalgia and muscular weakness. Any thoughts now? What is the diagnosis? Rash, muscular weakness. There is also some swollen fingers. Any thoughts? And the muscular weakness is also a bit progressive.
Myopathy.
Okay. In word of rheumatology, we'll call this as myositis. So, okay, it could be myositis, juvenile dermatomyositis. So we thought that this could be lupus. Later on, we thought that this could be myositis. Okay. But then what happened down the line is she started having progressive skin tightening, regurgitation of feeds and dyspnea. Now, thoughts. Progressive skin tightening down the line.
Nevia.
Sorry.
Nevia.
Sorry.
Scleroderma, something like that.
Scleroderma, fine. So there are lots of possibilities coming up here. One is lupus, one is juvenile dermatomyositis, another is systemic sclerosis. But actually, we need to define one disease. So what's the diagnosis here? So basically, this is, I'm coming to the next part of the talk, which is known as disorder, which is mixed connective tissue diseases. So basically, as we have seen in this index case, to begin with, there were features of Raynaud's photosensitivity rash. We were thinking lupus. Down the line, she developed dermatomyositis. We thought of juvenile dermatomyositis. And then subsequently, she had skin thickening. We thought of systemic sclerosis. So mixed connective tissue disease, to make it simple, as the name itself tells, there are features of simultaneous manifestations of signs and symptoms characteristics of two or more of the major rheumatic disorders. Like in the index case, they had features of lupus, they had features of juvenile dermatomyositis, and the girl also had a feature of systemic sclerosis. So these are the group of disorders which are known as mixed connective tissue diseases. Okay. So these are three terms which I would like to simplify here. So broadly coming, let's come to the fact that there could be an overlap syndrome, wherein one particular patient may have features of one or more connective tissue disease. For instance, this particular girl again can fit for the overlap syndrome. But what's the basic difference between mixed connective tissue disease is basically a form of overlap syndrome, which is characterized by very high titers of ANA and one particular antibody, that is anti-UN-RNP. So if you have overlap features of one or two or more connective tissue disease along with very high titers of ANA or anti-UN-RNP, you will classify that particular patient with MCTD. At the same time, there could be some patients, for example, let's go back to this particular patient. This patient may have just these features. Say, for example, this girl had landed up to you in January 23 when she was just having distal ulcerations or maybe gangrene only. Ulcerations will take time. So, I mean, Raynaud's only, because ulcerations and gangrene will evolve over time. Only Raynaud's phenomena, a bit of arthralgia, and nothing else. How would you classify this girl? And the bloods are normal, other things are normal. So what I mean to say is that there would be scenarios where you may not be actually, there are some features of connective tissue disease, but may not fit into the classic definition or classic diagnostic, may not meet diagnostic classification for any particular disease. So those group of disorders we will call as undifferentiated connective tissue diseases. And at times, as we have seen in MCTD also, the features evolve over time. So in some cases, I mean, in rheumatic conditions in particular, a patient follow-up is very, very important, wherein symptoms can evolve over the time and will, the disease, let the disease rise before a knee-jerk reflex in starting an empirical therapy. So what are the key features of mixed connective tissue disease? So as we have seen, these are characterized by clinical signs from at least two of the following diseases, which could either be lupus, juvenile dermatomyositis, systemic sclerosis, or GIA. And along with that, they will often have very high titers of ANA and anti-UN RNA antibodies, along with HLA predisposition from HLA-DR4. So, in fact, if you order ANA, what is the method of getting ANA done?
Indirect immunofluorescence.
Perfect. So indirect immunofluorescence you will do, and if it is 1:100 titers, it is positive, we'll consider that it is positive. But this is the only condition, as I am repeatedly highlighting the fact that high titers of ANA. So in that case, you may actually tell the lab that I'm suspecting mixed connective tissue disease and kindly run the titers in higher dilutions. And we'll come shortly that these patients often have a titers of ANA more than 1:1200 or so. And this is one condition where you usually will, for classifying someone as autoimmune disease or lupus, 1:100 is good enough. But here, probably there is a role of serial titers, serial dilutions of ANA, which could be positive. Okay. So, in summary, this is how these mixed connective tissue disease evolves. To begin with, they will often have features of lupus or juvenile dermatomyositis, and down the line, as the disease advances, the symptoms of systemic sclerosis will pitch in. So this is the most simplified way of demonstrating mixed connective tissue disease evolution. And this is what I was talking about, the criteria for mixed connective tissue disease. And here you can see that the high titers, and here is the titer more than 1:2000 of ANA, which is speckle pattern, is consistent with mixed connective tissue disease. And the clinical features are Raynaud's phenomena, synovitis, myositis, and swollen finger. To begin with, usually they will have swollen fingers and Raynaud's phenomena, and subsequently myositis, scleroderma-like features will evolve. So this slide just summarizes the classic clinical features and labs in systemic MCTD. Begin with Raynaud's, swollen fingers, myalgias, myositis. Very high titers of speckle pattern ANA, consistent with anti-UNRNP, and then down the line features of systemic sclerosis and their accompanying complications like interstitial lung disease, as in this case. So, contrast to lupus, MCTD has the chances of glomerulonephritis are less. But what is the most important cause of morbidity and mortality in these patients is interstitial lung disease and pulmonary arterial hypertension, and which are complications of systemic sclerosis also. So down the line, they will have dysphagia, they will have GI dysmotility, they will have PAH, they will have ILD. So major cause of morbidity here is interstitial lung disease and pulmonary arterial hypertension. So this is a table just to highlight the key differences in three seemingly similar conditions: juvenile lupus, MCTD, and Sjogren syndrome. So you can see that the lymphadenopathy and the glandular swelling are classically found in juvenile Sjogren syndrome. Raynaud's phenomena is more prominent in mixed connective tissue disease and lupus, whereas glomerulonephritis is an important cause of morbidity and mortality in lupus. Pulmonary disease is more important cause of morbidity and mortality in mixed connective tissue disease. As far as autoantibodies are concerned, ANA can be positive in all, but very high titers of ANA is characteristic of mixed connective tissue disease, and the anti-RNP positivity is again characteristic of mixed connective tissue disease, and whereas anti-Rho and anti-La antibodies are characteristic for juvenile systemic sclerosis. The major cause of morbidity, as again to highlight once again, is the renal and the other system involvement in lupus. In MCTD, the major cause of morbidity is pulmonary hypertension, lung, and of course, infection is an overarching for all the conditions. Lymphoma, fortunately, is rare in pediatric population, but they can have other features of morbidity like corneal abrasions, dental caries because of the Zika symptoms. So coming to the index case, how do we treat? Again, as we have discussed that the evolution of MCTD takes over time, and accordingly we need to treat depending on the symptoms. So this girl has Raynaud's, myositis, skin thickening, HRCT is consistent with interstitial lung disease. So it's a severe disease. And that's why we started with IV methylprednisolone, followed by tapering doses of steroids. We managed Raynaud's phenomena using nifedipine, hydroxychloroquine, tadalafil. And then because she had interstitial lung disease, we had started cyclophosphamide, which was given 6 pulses, and then uh, followed by mycophenolate mofetil. So in summary, the treatment would depend on the extent of the disease. For all rheumatic conditions, this holds true. Steroids an anchor drug, but the aim usually is to taper the steroids as early as possible and then use the other disease-modifying anti-rheumatic drugs depending on the disease. For instance, in MCTD, most important cause of morbidity and mortality in many of these patients would have lung disease or interstitial lung disease, which would warrant augmentation of therapy using either cyclophosphamide or mycophenolate mofetil or rituximab. And then Raynaud's phenomena is an important cause of more important clinical feature which needs to be taken care using calcium channel blockers. So what is the outcome? So outcome relates to the causes which may lead to morbidity and mortality in these girls. And these include pulmonary hypertension and interstitial lung disease. And for this, the treatment I have discussed in the previous slide, the acute inflammatory myositis and arthritic features usually wane over time, and it's the scleroderma features which are more prominent over the time. And we need to take care of infection, lung disease, and pulmonary hypertension. If we address on these three things, the outcome is okay in most of these patients. As in the previous series, the outcome was 33% of the patients, 1/3 of the patients were in remission at 16 years. So this is one, again, as I told that these disorders are rare. The last study is from India, and you can see that the usual age of presentation of these kids is around 10 years or so. And they often have Raynaud's phenomena, puffy fingers or swollen fingers at inaugural presentation. Subsequently, they develop sclerodactyly. And then the pulmonary dysfunction is an important cause of mortality and morbidity, as it is evident in most of the series, ranging from 20% to 40%. And then they can also have other manifestations of systemic sclerosis, like GI motility disorders and others. So mortality, it depends on the extent of organ involvement, and if you can control ILD and interstitial lung disease, probably it can be reduced. The mortality reported in various series ranges from somewhere 4% to 10% or more. But organ involvement in most of these cases is almost, as the disease progresses, they are likely to develop interstitial lung disease, and therefore these patients should be screened for a pulmonary function test annually, and preferably a HRCT also, and echocardiography. So we need to screen them using PFT, HRCT, and echocardiography for early identification of the major cause of morbidity and mortality in these kids. So clubbing together the entire presentation, I think if we can learn and take the message that when to suspect these disorders, it would be good enough. So an indolent course, persistent fever, off or rash, recurrent parotid swelling with constitutional symptoms, history of Raynaud's, please watch these kids more closely for evolution of symptoms, because as we have seen, most of the cases, the symptoms will evolve over time and before the obvious diagnosis is made, and therapy will be depending on the clinical extent of the organ involvement. So this is all about these two topics that have been assigned to me. And thank you all and all children and their families in our care. And I don't know whether Tanya is around. She has helped me with just taking out the data of the patient that I shared. Thank you so much, and happy to take any questions or comments.
Thank you so much,
Thank you, Dr. Bagri. Please go ahead, sir.
Yeah, Anika, thank you so much. Very interesting talk, actually. And Dr. Narendra has a very different way of making it more interesting by asking questions. So I could not also help in answering some of them in between. So that's very nice way of presenting. Very good. Bennett is also saying wonderful talk. Good, please. Very nice.
I request our chairperson, Dr. Nikhil Pathak, sir, to say a few words. Dr. Pathak?
So it was a very excellent presentation by sir, and we got to know a lot of things about Sjogren syndrome, and we also saw how the kids progressed. So it is a good learning experience. Thank you, sir, for your presentation and spending the time with us and giving your valuable time for the audience. So it's a pleasure to be in this meeting.
Same
Thank
here.
you.
Thank you, Dr. Nikhil. I request Dr. Anu, who is our academic coordinator, to say a few words. Dr. Anu, are you there?
I think we can take the questions if Anu is not here.
Yes. There is one question by Dr. Smear Bede. Do we need to take ENT consultation in Sjogren syndrome?
I mean, actually speaking, you don't need to take consultation. The first study I showed, the patients were actually going to ENT for the recurrent parotid swelling. So I would say that you need to,
Okay.
of course, I would say have coffee with your ENT colleagues and then discuss over coffee table that if patients of recurrent parotitis think Sjogren.
So, Dr. Bagri, I want to ask a question myself. My mother, she is a patient of Sjogren syndrome, and her main features are she has a very dry mouth, and many times the food gets stuck, especially when she takes rice. And we
Yeah.
also advise her that you take chewing gums before you
Yeah.
start food, which she does sometime, but many times she doesn't. So apart from that, there not been any features of she has dry eyes, so use teardrops.
normally जाते हैं सर.
So for her, as you said, that the risk of lymphoma is very high, especially in adult Sjogren. So there is any routine screening of these patients of Sjogren to look in the possibility of lymphoma? Any tests to be done routinely, or it is just symptom based?
That lymphoma is usually if there is glandular swelling, and that, I mean, there should be clinical manifestation, and probably the biopsy, I mean, the threshold for biopsy should be low. This is my take, but we don't see that in kids, so I'm not very sure. Maybe adult rheumatologist would be better to
Now, that
ask.
is, it is going to be a lifelong disorder. So ultimately,
Yes.
throughout the life, you need to take these precautions like teardrops and
Yeah,
chewing-gums or
yeah,
something like
that's
that.
the bad part. I mean, the quality of life is actually hampered. As you are telling before, it's easier to prescribe, chewing gum before meal, but then even if we are asked to do so, it will be very, very painful. But at the same time, we need to develop some maneuvers. For example, chewing gum is one. Another is there are these pilocarpine hydrochloride sprays are available, which might be of help in increasing this. And for sure, teardrops are very, very important. Reason being, if they don't address this, then this can cause damage to cornea and at times further complications.
Right. And also, we had a patient of complete heart block, and we were only thinking about that the mother has lupus. But ultimately, the mother, when we investigated, she didn't have lupus, but she had Sjogren. So we
Yeah,
should understand that it's, as a pediatrician, as a neonatologist, you always think about maternal SLE and complete heart block, but it can be maternal Sjogren and complete heart block also, which is not very commonly thought by a neonatologist.
Thank you, Dr. Pankaj, for bringing this out. Actually, I missed this point because in Sjogren syndrome, particularly, this may not be much relevant in our country, but teenage pregnancy issues. But whenever it is a girl with Sjogren syndrome is conceiving, there is high chances, as you mentioned, that of neonatal lupus, like in SLE. In fact, many of these patient mothers would have Sjogren syndrome.
Dr. Anu, please go ahead.
Good morning, sir. Sir, sorry, there was some issue with my connection in between.
Okay,
I
no
missed
problem.
the last two slides of Dr. Bagri too. Sir, I think a very enlightening talk, sir. Sjogren's is not that common in childhood, but sir, we do see a few cases And so one more thing I'd like to add here, if Dr. Bagri would agree, he talked about immunoglobulin levels. In fact, we had children with Sjogren's where we screened them. When we diagnosed them, they turned out to be common variable immunodeficiency. So if a very young child is coming with autoimmunity, Sjogren-like symptoms or lupus-like symptoms, it's very essential that we should screen them for underlying inborn errors of immunity, as has been told many times. And sir, thank you for giving me this opportunity to do this wonderful rheumatic course, and all my fellow colleagues and the esteemed faculty members, my seniors. I think I'm a little nostalgic. I'm waiting for the next Sunday. Okay, the next talk. So what's next? In fact, I got a few
Dr. Anu,
messages from our students saying, "Ma'am, we are very sad. The course is getting over." So let's make it. I think so. We should do this maybe annually or something like that. Make it
yeah,
more
sure.
better.
Maybe we'll plan it next time. Next Sunday, we are starting with the cardiology. Dr. Pankaj, sir will tell few words. And
Yes,
about the
sir.
certificates also, sir, Dr. Pankaj.
Sir,
So,
about I ask one
as
doubt.
yeah, this is the last session. So, I have a request to make to all the faculties and chairpersons of all the sessions, and Dr. Anu can coordinate that. All the speakers in these sessions, I think there are 10 of them. You are most welcome to join our PAT conference of North India PCNI on 31st August as our guests.
Thank
There
you,
will
sir.
be no registration for you all, and you will be also, I think most of you are from Delhi, so I request you to please join us. We are going to felicitate all of you in our
Thank you.
inaugural function, which will be on 30th of August. And I also request all the chairpersons of all the sessions to be our valued guests on in the PCNI program. So it's only because of the excellent faculty and the chairpersons that this program has become successful. And I can see that the teaching which has been imparted by these sessions is going to a long way, not only during live sessions but also later on when these recorded sessions are there on the platform of IIP Delhi and people keep on listening to them. And I also again say that please join our North Zone Pedicon, which is allowed with PCNI on 30th and 31st of August, and it is going to be in Connaught Place, Lee Meridian. Please join us in large numbers at that conference also. And from next Sunday, we are going to start the pediatric cardiology session. So with these, and I think Dr. Sham has also joined. So thank you all the
Before that,
office
Dr.
bearers.
Bennett, sir, wants to ask something.
Yeah, please,
Dr. Bennett,
please.
sir, please go ahead.
Thank you,
Morning,
Pankaj,
sir.
sir.
Thank you very much for inviting me for all the sessions. It was a wonderful experience. Sir, about today's talk, one doubt and another suggestion. Suggestion is already written in the chat box. And my doubt is regarding the recurrent parotitis. Suppose, so how many numbers we can say that to say whether it is we should think of or evaluate this Sjogren syndrome? And if you think like that, like you got a parotitis, and if you don't have any other features, means you got a recurrent parotitis, but no other extra features, then should you think in terms of Sjogren syndrome? That is my doubt.
It's a very relevant doubt, but no real answer. So usually, I mean, as we have discussed, I have shown the table. If there are parotitis without constitutional symptoms, probably the possibility of Sjogren is less. If someone is having 2 or more episodes of recurrent parotitis, we should think, and as you rightly pointed out, we should also rule out other causes like lithiasis or stone in the duct. That's one. And but typically these patients, those with juvenile recurrent parotitis would present a bit early without constitutional symptoms, and presence of pain usually favors this entity rather than Sjogren syndrome. Sjogren syndrome often will have parotitis along with other constitutional symptoms, may or may not be painful swelling.
Okay, so thank you very much. Second suggestion is, instead of chewing gum, can we use the
Yeah,
tamarind?
yeah, I think there is a good, it's the only scientific basis to stimulate it. In fact, for doing scintigraphy, they would, some centers would give lemon.
Yeah, sir, the main thing is if you suggest the chewing gum in our talk
Yeah.
and all, The problem is, I heard that.
I do agree.
I don't
yes.
know. Without any search, and I am
No, it's
seeing about it.
perfect.
It may not be good, like chances of cancerous conditions and all. Some thoughts are, but I don't know about it.
Agreed,
It's a
agreed. I
natural
think
thing.
something which is palatable and increases saliva production should be good enough.
Thank you, sir. Thank you, sir. I
Dr.
request our
Ajay,
secretary, Dr.
few
Shamina,
words.
sir.
Dr. Ajay, can I speak few words?
Yes, sir. Yes.
Okay. First of all, congratulations, Dr. Narendra Bagri, sir. Very, I will say, the pinpointing the every aspect and then very illustrative talk. And I will request, I have not attended the previous ones. If there has been any class for the clinical approach to a child with arthritis, this will be very beneficial for the postgraduates. This will be very.
Sure, sir.
Sir,
We will
we
plan.
had
So
a session on JIA that was
We'll plan
approached
one
to.
as a standalone webinar. Don't worry.
Okay. So can we get the this one, the tube link or anything for the postgraduates? They can just go through
Sure,
that,
sir.
na?
Sure. I'll share the link.
Please provide, है ना? Thank you so much.
Okay.
Thank you once again, Delhi IIP, for giving this opportunity to join. Thank you so much.
Thank you, sir. Dr. Shamina, sir.
So, Narendra here nicely present today's session. Definitely, that is very informative. I have
You're
the
not audible, Sham. You're not audible.
hello.
Please go ahead. Please go ahead.
I have the small query. What type of the lozenges you frequently prescribe? Because we also have the many autoimmune kits that also have the Sjogren's like the feature. We frequently advise the lozenges that contain the sugar. That is might be harmful for the kid. So what in the market is like the Ricola LCT lozenges are frequently available. They have the sugar free, and some of the homeopathic lozenges or like the sugar mint type products are available. So what type the lozenges are the basically more useful in these children's? Because most of the lozenges contain the sugars like the saccharin that might be carcinogenic or might be harmful for kids.
So good question. So if you look at the recommendations, they would say sugar-free lozenges. So I think one has to struggle to find them out, but they are available with some struggle. I mean, but they should be sugar-free, as you rightly mentioned, because I'm not sure about their carcinogenic potential, but of course, for sure, too much of sugar is not advisable. Reason being, they will also predispose for dental caries in these patients.
Because due to this issue, many parents they said that the child the sport activity is limited. So that's why we need the frequently this type of the product to promote the physical activity of these kids.
Yeah, but I mean, fortunately, the number of kids with these are very, very rare. And as my colleague Dr. Bennett is pointing out, we need to give some indigenous sources. Like maybe if tamarind can, or something can promote that is good enough. But for sure, sugar-free lozenges.
Okay. Thank you, dear. Over to Dr. Ajay.
Sir, any announcements, Dr. Shamina, sir?
We already you announced and we are the next because today's our last session about the rheumatology course. After a very great successful on a very energetic response of the resident as well as our clinician, we are the next planning to launch the cardiology classes. That is a very informative. We got a lot of the resistance for that e-classes, and subsequently we got the opportunity to hold the North Zone Pedicon along with Delhi State Conference. That is a brand name is PCNI. So I request to all respected faculties, chairpersons, and participants of these e-classes kindly registered, and we definitely you get the lot of the academic benefit.
Thank you, sir. So I also thank Dr. Dolly Madan and Dr. Neha for coordinating these sessions. And Dr. Anu has been a wonderful academic coordinator, and she coordinated with all the faculties and had the best out of them. And all the faculties were great, and all the chairpersons were very, very knowledgeable and helpful. And I thank Dr. Pankaj Garg and Dr. Shyam Meena sir to give this opportunity to me, and our office staff who coordinated all Sunday mornings. Thank you very much. I request all delegates to please join the cardiology course also.
upcoming conference is North India Pediatric Infectious Disease Conference in June, and North Zone and Pediatric Conference of North India on 30th and 31st of August. To register for that also. Thank you very much. Thank you.
Thank you so much, sir.
Mr. Sushil?